Hi, everyone. Thanks for joining us and welcome to this session of the 2022 Culture of Data Conference. My name is Allison Rosenthal, and I will be moderating this session, and my pronouns are she, her, hers. We also have Kelsey Fife Duarte. Her pronouns are she, her, hers, and she's going to be managing the Zoom and making sure the tech is all running smoothly. You are all muted now, but if you have a question during the Q&A session, please feel free to unmute. You can also use the chat box if you have any questions or need anything. And if you are comfortable doing so, please add your pronouns to your Zoom name by clicking the three dots on the video square and selecting Rename. This session has been generously sponsored by Champ Software, so we thank them for their contributions to this conference. Crystal Martins from Champ Software is here, and she's going to share some information to us. So take it away, Crystal.
Hi, everybody. I'm Crystal Martins. I'm the marketing manager from Champ Software. And if you're not familiar with us, Champ Software is an electronic health record vendor. We were founded by a former community health director, and his goal was to build software that could meet the unique needs of public health agencies. So our EHR is in use in more than 130 public health departments across the US, and we love public health. You guys are the heroes. The COVID-19 pandemic has just reinforced the dedication, the heart, and the effort you all give to your communities every day. You work tirelessly, you give generously, and you show up day in and day out, whether you get the appreciation you deserve or not. But that does not mean that you don't deserve appreciation and validation. Our company tagline is "We believe in public health," and that's really true both on a company level and a personal level. Our goal is to help public health officials accomplish their mission to deliver high-quality care to their communities. One of the ways we do that, and it's really relevant to this conference, is by helping you collect important data and then create easy-to-read, easy-to-understand reports and dashboards that can turn your data into actionable knowledge. So our EHR offers you the ability to prove what kind of change a program is affecting in your community, know where your dollars will be most effectively spent and what areas most need staff, have reports and visuals you can show at a health board meeting to justify decisions or support budget or personnel requests, collect impactful data that you can share with legislators or use when applying for grants. And we can offer you this because our EHR is built on standardized terminology. Standardized terminology, if you're not familiar, is a common language for entering patient data into the medical record keeping system. It ensures data is consistent, objective, and measurable, and can generate meaningful reports. To guarantee clean, meaningful data, our EHR is one of the only EHRs that allows you to enter every piece of data using standardized terminology. We offer a series of reporting templates tailored for public health and the ability to collaborate and share knowledge with our growing community of public health departments. So I'd just like to end with a quote by Karen S. Martin. She's a healthcare consultant with Martin Associates, and she's a really strong believer in the vital role of standardized terminology in the future of public health. Having quantitative data demands that huge amounts of data are collected and processed. However, that data remains largely in EHR data cemeteries, and that's what we have to get away from. We have to move from collecting data to using data. We need to convert data to information, knowledge, and wisdom. Like Karen said, converting data to information, knowledge, and wisdom is vital to the future of public health and the success of public health initiatives like Public Health 3.0, Healthy People 2030, or fulfilling the 10 essential public health services. And our job is to provide you with the tools to get that information, knowledge, and wisdom. So if you'd like to know more about us or see a demonstration for EHR, you can contact us through the sponsor page in the app. Thank you so much for your time, and happy National Public Health Week.
Oh, thank you, Crystal. So I just wanted to now dive into our presentations today. So we have 3 presentations during this session, and each will be 20 minutes, and we'll have a 10-minute Q&A session at the end of the presentation. And because there are going to be no scheduled breaks, please feel free to take them as needed. And the theme of the session is community-centered vaccine outreach. And this topic could not be more appropriate for our conference theme on the impact of the pandemic and how we rebuild a stronger public health sector with stronger community partnerships. Our first presentation is reducing vaccine disparities using a community-centered approach, presented by Anna Brown-Cohen, Kristen Legreese, and Tim Wagner. So take it away. Thank you.
Thanks, Allison, and thank you everyone so much for joining us today. We're really excited to be here and to kick off this session. So I will let Tim pull up our slides. Thanks, Tim. Great, so as Allison mentioned, my name is Anna Brown-Cohen. I'm the Director of Health Programs at Colorado Access, and I'm joined today by my colleague, Tim Wagner, Health Program Specialist. And today we are excited to share our presentation on reducing vaccine disparities using a community-centered approach. In today's presentation, we're going to start off with a quick overview of Colorado Access, set the scene for what COVID-19 looked like in Colorado when we started this work. Tim is going to dive into our vaccine strategy and some of the programming that we offer, and then we'll wrap up with program outcomes, as well as some of the innovative ways that we've continued to look at our COVID data as we move forward. So who is Colorado Access? We are a local nonprofit health plan that served Coloradoans for over 27 years. Over that time, we've had experience as a Medicare Advantage plan, a single entry point entity, and provider of long-term support services. Currently, our two primary areas of focus are Health First Colorado, which is Colorado's Medicaid program, and we are also the largest Child Health Plan Plus, or CHIP plan in the state. At any given time, we serve over 500,000 Medicaid and CHIP members. However, we can't do this alone, and we rely heavily on the expertise and experience of our community to do this work. We know that we can have the biggest impact when we work together with our community partners and our provider network to collaboratively improve the health and well-being of our community and of our members. For those of you who might not be familiar with Medicaid in Colorado, the state is divided into 7 different regions, and each region has a contractor who's responsible for managing the physical and behavioral health and care coordination for Medicaid members. Colorado Access oversees 2 of these regions, Region 3, which is Adams, Arapahoe, Douglas, and Elbert counties, and Region 5, which is Denver County. So now I'm going to turn it over to Tim to talk more about our COVID-19 programming.
Perfect. Thank you, Anna. So I'm going to go ahead and start off with just a little background information about our funding and the need for this programming. So I won't spend too much time on this slide, but this is a brief overview of that FEMA funding. So under that National Emergency Declaration, FEMA funds were made available to combat COVID-19. The goal of these funds was to improve the abilities of communities to effectively respond to the COVID-19 public health emergency. And these reimbursements really did play a critical role as state, tribal, and local officials worked tirelessly to assist their communities. So this slide is going to look over some of the data from back in April 2021 and the need for this program. As we see here, Colorado was doing pretty well as compared to the national average for vaccinations. Where we start to see some of the disparities was amongst Medicaid versus non-Medicaid individuals. Diving into the data a little bit more, we saw some disparities between race and ethnicity as well. So this showed the need for COVID-19 vaccine programming that included concentrated efforts on supporting high-need subpopulations. We identified 3 being our homebound members, members of color, and our rural members. So now we knew what the issues were that we wanted to address, so we set out to accomplish 3 goals. Those were to increase COVID-19 vaccination rates in Medicaid and CHIP Plus members, to reduce the vaccine disparity rates, and to implement sustainable strategies to continue to increase vaccination rates among members. We accomplished these goals and objectives through the FEMA funding, which the state distributed to the RAISE. Colorado Access received over $6 million to design, implement, and put out their vaccine programming in each of their regions. So now I'm going to go a little bit more actually into our strategy and specific programming here. So our population management approach is actualized through 3 key channels: working with our members, partnering with our providers, and collaborating with community partners, especially those that focus on offering key social services to Medicaid populations. Noted here are a couple of key streams that funnel from each of these channels. The success of work of any of these areas require a partnership with our communications team, who supported electronic communications both internally and externally. All of our member programming utilizes a comprehensive integrated approach that includes a variety of communication channels. Our goal is to share information and resources through as many avenues as possible to meet the members where they're at. So we designed our internal programming using a multi-pronged approach that allows us to communicate pertinent information to our members quickly and by using their preferred method of communication whenever possible. Our vaccine programs include digital engagement and live agent interventions, which are outlined here on this slide. You can see that we were able to tailor channels and the messaging that was sent to members according to our priority populations. As mentioned, those were our homebound members, members of color, and rural subpopulations, in addition to sending out mass communications to our entire membership. So looking at this a little bit more, for our digital engagement intervention, we used IVR calls as well as SMS texts. And then we also did utilize direct mail. We included direct mailers in order to ensure that there weren't any gaps in communications. We would send the same information that was included in the text intervention to our members that did not have a valid phone number. We also tried our best to reinforce the messaging using multiple touch points. So for example, members who received a text may also be in contact with one of our care managers. And speaking of our care managers, they would call members on our COVID vaccine outreach lists, prioritizing homebound members and members of color. Our care managers also supported members in scheduling vaccine appointments and sharing resources such as the Colorado Vaccine Phone Line, the state of Colorado's COVID vaccine website, or encouraging the member to contact their primary care provider to schedule an appointment. They're also trained to work with members who may not be sure if they want to get the vaccine or not, and they were able to educate these members on vaccine efficacy, cost, where to get the appointments in the community, and also how to access transportation to and from the appointment if they did not have their own transportation. And finally, community and provider collaboration. In an effort to ensure comprehensive regional strategy, we work closely with community partners and our network, provider network, who are already working with these populations in order to develop key messaging and resources to use. Another major change that Colorado Access put into place in the beginning of the pandemic was around our telehealth services. As many of you know, telehealth services were heavily promoted early on in the pandemic as a strategy to continue serving members, even when many businesses and doctors' offices were closed. This was especially important for our members, as many of the hurdles and access issues that people across the country were experiencing were compounded for low-income populations who are already experiencing issues with access to care and transportation. In order to better support our members, Colorado Access opened a variety of telehealth place of service codes to be billed for reimbursement by contracted providers. This was later reinforced by public health emergency order at the federal level. Colorado Access played a huge role in sharing telehealth information to support our partners in both implementing these changes in their own practices, as well as working with other members to understand and utilize telehealth services. So this slide here is just a quick screenshot of one of our mailers that we would send out to our members. So the messaging within these mailers were tailored to address vaccine safety, efficacy, cost, and return to normalcy. Not only was this developed internally amongst our team, we also brought the messaging and the design of the mailers to our Member Advisory Council, or MAC, in order to gain feedback to ensure that the messaging addresses the needs and the concerns of the community that we serve. Each mailer was designed with the diversity, equity, and inclusion lens in mind. So making sure that we tailored the messaging to the concerns of the different populations in Colorado. The mailers were also made available in Spanish to accommodate our non-English speakers in our region. This slide here has a screenshot of our booster mailers that were sent out to all eligible members. While our other mailers did include information regarding booster shots, with the need and effectiveness of the booster shots, we did determine it would still be beneficial to include a booster-specific mailer that went into a little bit more detail about what boosters are, how they work, and the schedule and the timing for each booster based on the vaccine we got originally. So now we're going to talk a little bit more about our providers and our community partners. So Colorado Access had chosen to pay 100% of the dollars received to primary care providers who serve members in zip codes that were identified as COVID hotspots, as well as those serving a high volume of members of color. The evidence clearly showed disparities in vaccination rates between members of color and members who identify as white. Colorado Access felt that it was imperative to channel this round of support to providers who are most engaged with these members and demonstrating success with that vaccine administration. Our community partners also played an integral role in the development and distribution of COVID-19 messaging and vaccination outreach. Community partners aided in the appropriate creation of communications and messaging, as well as the facilitation of information sharing across trusted public health messengers. Colorado Access again used hotspot areas to identify partners in vaccination efforts. and the community partner organizations and behavioral health providers that were directly assisting members of color, potentially homebound persons experiencing homelessness with getting vaccinated were eligible to receive the direct payments from Colorado Access. While our colleagues will go into a little bit more detail about our community efforts and programming in the next presentation, I did want to highlight one example of an initiative that we conducted with community partners to outreach our BIPOC members who we know are at higher risk for poor health outcomes, have lower vaccination rates, and are often likely to face more challenging accessing care. For this project, we partner with Korea Results. Korea uses a Promorta model to canvass and outreach residents in Northeast Denver neighborhoods. We work with Korea to identify overlapping priority areas based on COVID immunization and member zip codes to identify highest need neighborhoods that you can see here on this slide. Through canvassing efforts, vaccine clinics, media, and community outreach efforts, we are able to outreach almost 200,000 community members. A couple other exciting partnerships that I do want to highlight include a partnership between one of our network providers, Stride Community Health Centers, and the Aurora Public Schools. Together, Stride was able to administer vaccines to students, their families, and other community members after regular school hours. We also partnered with Behavioral Health and Wellness Program at the University of Colorado to develop a training for network providers to help them better support vaccine hesitant members. And the training was so successful that we actually partner with other regional entities or RAIs in order to expand this offering to their network of providers as well. And now I'm going to hand it back off to Anna to go over our program outcomes.
Thanks, Tim. So now, like Tim said, I'm going to share some of our outcomes from our FEMA scope of work, as well as go into some more detail around the innovative ways that we've been able to look at and use our COVID-19 data. So this slide is just a written summary of some of the pieces that Tim mentioned on the previous slides and what I have for the remainder of this presentation. So for time's sake, I'll just move us on to the next slide. So this is some outcomes that we wanted to share from our FEMA scope of work. If you recall from Tim's portion of the presentation, one of the main goals of this work was to reduce the vaccine disparity between our members of color and white Caucasian members, knowing that certain groups, like Tim mentioned, are more at risk for poor health outcomes and may have more issues around access to care, things like that. Colorado as a state set the goal for each of the RAIs to reduce that disparity to 3% or less. So you can see from this slide that we were able to successfully do that in both of our regions. The other thing that I wanted to point out, where you see the peak on these line graphs was around May. That also coincides with when we implemented our care management digital interventions and when a lot of our work with our community partners and provider networks really intensified. And so while we weren't able to conduct any sort of statistical analysis to show a relationship between the interventions and this rate reduction, we can infer that these interventions and the partnerships really had a big impact on reducing that disparity as you see over time. The other piece I wanted to call attention to here is in that bottom left part of this slide. This is a tool that we used mostly with our community and provider partners when we were figuring out how we could do targeted outreach and where we wanted to focus our efforts and things like that. So obviously the map looks at vaccine rates by zip code and is a nice, easy way for us to look with partners to see where to focus. Similarly, that bubble graph in the left side of that graphic, that looks at zip code data, level data, includes our race ethnicity data and the vaccination rates for each of those zip codes. It's also color coded by county. So again, when we're working with different partners across our regions, that was really handy in being able to help set everyone on the same page. Next slide, please. As we completed our FEMA scope of work, the data that you see on this slide was really in the forefront, or has come to the forefront of our efforts now and moving into 2022. You can see here the average Medicaid vaccination rate in green as compared to the general population vaccination rate in red. We're happy to see in our data, which is those blue bars, that our counties, with the exception of Elbert County, hover around or above that Medicaid average. However, as you can see here, the Medicaid rate is lagging pretty significantly behind the general population rate. This is true not only in Colorado, but we're seeing similar trends across the country. And so, and then that this has also increased a little bit as that 5 and older population got added into those who are eligible for the vaccine. So when we're thinking about how do we continue this work in the future, this is something that will really drive our efforts and where we want to focus our programming. The next 2 slides are snapshots from our COVID-19 dashboard. We have a dashboard of vaccinated members and unvaccinated members. This is really a nice way to look at the population level data of our membership. So you can see the fully vaccinated members, a cumulative total of that, and then you can see how members were going in to get their vaccines over time. The other piece, as Tim mentioned, was that we recently started getting booster data, which we've added into these dashboards, and has helped us to design and implement our booster initiatives to get members to come in to get those booster shots. The last data piece that we wanted to share with you today is a look at some of the different variables that we take into consideration when we're designing different programs like our COVID-19 program and other health programming. We know, like Tim mentioned, that certain groups are more susceptible to poor health outcomes. And so when we think about risk stratification and how we want to target efforts towards different groups, what sorts of messaging or resources, things like that, that we might want to change depending on who our target outreach group is. These are some of the pieces that we'll look at. So things like race and ethnicity, gender, and age. The other piece that I wanted to draw everyone's attention to is the bottom left pie chart, which looks at vaccination and engagement. When we first started looking at these data, we looked at members who had come in to see their primary care provider in the last year. And this, when we first started looking, was pretty correlated to the engagement and then whether or not that member had a vaccine. So again, when we're thinking about who we might be able to have the most impact on in terms of getting them to come in to get a vaccine, this was one group that we chose to focus on. As you can see, it's changed a little bit over time. Again, we think that's attributed to adding in that 5+ population, but again, still a very useful tool when we're thinking about population segmentation for COVID or really any other kind of health programming. Right, so in summary, lessons that we learned and felt were really helpful to the success of our programming. One obviously was using a member-centered approach, being able to risk stratify or segment our populations based on their unique needs, developing targeted interventions, messaging, and resources to share with those various subpopulations, and making sure that they're age appropriate and align with national guidelines and standards. The second piece is, having a systems level or community-centered approach and understanding that we're not necessarily the best entity to be delivering care all times to our members. And so rather than reinventing the wheel, where can we support community initiatives and work that's happening that we can see as demonstrated success. Third, the importance of having appropriate access to SIS in this case, or really any sort of member data that we're looking at a systems level. Through our COVID work, that really came to light that depending on the entity or provider, everyone had different pieces of information. And so as a regional entity, we were able to play a really important role of being able to standardize what data everyone had access to, develop methodologies, like Tim mentioned, different hotspotting methodologies and risk segmentation models that we were then able to share with our partners so that they could conduct their own outreach for their members. And then last but not least, the importance of continuous improvement and enhancement. As you can see, we're continuously looking at our data sets to understand, are we having the impact that we want to on our members? Where are there opportunities for improvement? And this is especially important as, we know that COVID's not going away. So as we move into more of an endemic phase, taking lessons learned, outcomes from our programs, and using those to inform this work moving forward. So that's all that we have today for you. Thanks for having us again. And I don't know if we want to move Allison into the next session and hold questions till the end.
Yes, we will move on to our next presenter. Thank you guys so much for that presentation. That was really informative. And our second presentation is leveraging community leaders to increase vaccination rates among Metro Denver's Latino population. And this is going to be presented by Julissa Soto and Julia Mecklenburg.
Hello, everybody. Welcome. My name is Julia Mecklenburg. I am also with Colorado Access, so you'll be seeing similar slide setups, different graphics for this presentation. I am the Senior Community Engagement Liaison. I'll be the MC of this presentation, but the true star is my co-presenter, Julissa Soto, and I'm so honored to be here with her.
Honors mine, Julia, and we can see anything in the screen. So maybe you can fix the screen, put the presentation in the meantime that I introduce myself. My name is Julissa Soto. Yes, you have the two slides in there. Let's change it to just one. My name is Julissa Soto, and I'm a health equity consultant. I have been in the nonprofit world and working with government agencies for more than 23 years. It's sad to say because now you're going to kind of calculate my age. So I don't want to talk about my age, but I do want to talk about my work in grade 3 and 5. So guys and girls and everyone, get it ready, put your seatbelts, and we're going to start a great presentation. I'm an extrovert, so I like looking at you guys. So if you can turn on your screen, but if you don't, that's okay, because still my voice is going to keep you awake. This is a fun presentation, and let's do it, Julia.
Awesome. Thanks, Julissa. So fortunately, Anna and Tim did a great job introducing Colorado Access, so we can just breeze right through that. Then we will discuss our Latinx population disparities overview, what we have seen from the data, what we have heard from the community from Julissa. We will be reviewing best practices we have learned during our COVID vaccine outreach. Again, coming from the community, coming from our leaders like Julissa, what she has learned as well. Colorado Access unique approaches, and then future opportunities and lessons learned. So moving on, like I said, you have seen these slides. So please feel free to review them at your own pace. So for our first topic, overview of disparities among Latinx Medicaid members, we are going to start with all of our graphics in August, as that is when we began contracting with Julissa. So that's kind of the snapshot that we'll be showing you. Most of the graphics will go from August to December so that you can see through 2021 our work with Julissa and how that impacted our vaccine rates. So in this slide, you will see that the Colorado Access COVID-19 vaccine rates for our Latinx members, again, if you recall from Anna and Tim's presentation, that's Denver County, Adams, Arapahoe, Douglas, and Elbert counties. So from August to December, we went from 30% of folks fully vaccinated to 37.4. And I know, Julissa would like to talk about what this data means to her and her community.
What that means to me, guys, is that I'm excited to see that I got the number from 30 to 37, but the work must continue. I am not happy with this number. And that's all what I can say. Colorado Access, right now we're working together, get into the community, get into the hood, to the barrio, and see what's happening, right? Educating the community. And I will talk about more best practices, but don't think because I see the number 30 to 37.4%, we're excited. No, and we still have a lot of work to do. It's a progress, but it's a progress that Julissa Soto is not satisfied yet.
Thanks, Julissa. We definitely are not either. So this next slide will show you Julissa's monthly vaccine clinic rates. So Julissa runs her own vaccine clinics. Again, we have a contract in place with her to help fund those clinics. And on this graph, you'll see there was a spike in November, and Julissa began running her vaccine Sundays. Julissa, do you want to tell us about vaccine Sundays?
Yes, for sure. Vaccine Sunday, what it means is that in any given Sunday, you're going to see me in grade 3 or 5, which is Denver County, Adams County, Arapahoe County, Albert, and Douglas. In counties, you will see me speaking during church. So I just don't make an announcement. I memorize the homily of the day. So I combine the homily. For those who are not Catholic, is just the scripture of the Bible for that day. So the homily with vaccines and public health, and that's how I get to speak to my community in a way that resonates to them. You know, when I'm speaking about God, I'm speaking about how we need to take care of ourselves. I'm speaking about Pfizer, Moderna. I'm not allowed at churches to speak about Johnson & Johnson. So I speak about Pfizer, Moderna, the homily, and that's when we see a big crowd of people. My first time speaking about vaccines and vaccine Sundays through church, that's just in one day, I vaccinated 1,272 Latinos, just in one day. So my clinics were booming, and we're gonna talk about more about what has been successful, challenges, and everything else. And as you can see, the numbers in March are still low because we have not had the time to add the data into this graphic, but I will give you my numbers for the month of March, which is no shame on my game. I'm so proud, guys. Check this out. I attended 20 masses. I'm holy by now. Just kidding, guys, just kidding. But 20 masses speaking to a captive audience of 7,850 Latinos. I vaccinated just in the month of March, 890 Latinos. And I did COVID testing because we have the only bilingual testing site in Montelle. I do also testing in that church. We tested 38 people. Plus, I don't know if you guys know that we also offer the COVID testing boxes, the home test box, just in case somebody might not want to come to the church and don't trust the system. I went and knocked on people's doors. Guess how many homes I knock on people's doors? How many homes? 12,870 just in March. Walking, I have great legs by now. It just approaching my community in a very cultural, relevant, and respectful way. So those are the numbers for March.
Thank you, Julissa. She does some amazing work, as we will continue to discuss. So this is a comparison of COVID-19 vaccination rates based on race and ethnicity. And the blue lines are actually state. So these are folks who are not on Medicaid, and the green shows Medicaid members. And again, these are in our 2 regions. So as you can see on this graph, right now, the only population that is showing where Medicaid has a higher vaccine rate than the general population is the Hispanic Latino. And we contribute that greatly to the work that Julissa and a couple of our other partners who we contract with are doing. We are so grateful for all of your hard work. But as you can see, there are definitely other populations where there is opportunities to replicate the work that we have done with Julissa, and we hope to show up more in those communities to get those numbers up as well. So this graph shows the data that we got at the end of December, so December 31st, which shows that 59.4% of our Latinx members were not vaccinated. And this was just a few months ago. Julissa, do you want to talk about that?
Yes, again, when I see those numbers, it's like you guys are pulling my hair like that. I'm like, oh my God, where's my people at? But you know, Colorado Access is trying really hard to get into those homes, to get into the families and speak to them in a cultural relevant way. Like I said, we're going to the communities, we're at the barrios, we're not in Cherry Creek, guys. We're in Montbello at 5 p.m. at night talking to people, and then till 10 p.m. And I know that number should be a little bit lower because we don't have the numbers from January, February, and March, but still, that's a high number. And I know that for many of you guys who are here and are Latinos, those numbers should have surprised you guys, right? Because we were all left behind all the time on chronic conditions, cardiovascular disease, diabetes. We have always the lowest rates and, you know, the highest rates on everything, and the lowest rates when it comes to approach in a very cultural relevant way. Colorado Access is working on that at this moment as we speak. And I know that that number is going to be lower and lower and lower.
Thank you, Julissa. Because of all your hard work.
Right? I'm going to hustle vaccine, guys. I'm going to hustle vaccines.
All right. So with all this hard work that Julissa has been doing, we have definitely learned some best practices. So I'll be reviewing the first two, and Julissa will be reviewing the rest. So data-informed outreach. When COVID-19 first hit, we developed a strategy. Anna and Tim discussed this a little bit, where we did a zip code strategy and identified the areas in our regions where there was the lowest vaccine rates, and who those community organizations and communities leaders were within those zip codes that we could partner with to increase vaccine rates in those areas. And out of this came our contract with Julissa, which is awesome, and a couple others, which I will be reviewing in just a few slides. But Julissa, if you want to take it from here.
Yes, eligible but not enrolled. You know that many people in our community still hanging on to the public charge, right? And many Latinos who are applying for citizenship are very confused. Should I apply for Medicaid or not? Is this going to affect my status, my citizenship? So I've been working with people that has green card, with undocumented, with those who are citizens, and trying to explain to them how if you personally apply for cash and food stamps, that might affect your citizenship status. But if you're only applying for Medicaid, you and your children, you know, that doesn't affect in any way, because when I went through the immigration process interview, they asked me, have you applied for any benefits? Which my kids at that time were on Medicaid, right? And I said, my kids have Medicaid, and they're like, no, we're asking about you. So my responsibility towards that community is to speak about the public charge is no longer into effective. It's no longer effective, right? So my job is to get to the community and explain again in a cultural relevant, respectful way that this is not going to affect if they apply for Medicaid, and to the contrary, you will do a big favor to the state by not running to the emergency room. So I do explain to my community what it is, evening and weekends, right? When I started noticing that many of my colleagues were saying that it was a lot of hesitancy around vaccines in my Latino community, right? And you guys have to remember, I'm part of the community I'm speaking about, you know, the monolingual Spanish-speaking immigrant community. I'm part of that community. I wear two hats, the professional and then Julissa from the block, right? I'm the Mexican when I come home and Julissa from the block, but then I'm the professional that you guys see, right? So I know what my community needs. So when I start seeing that most of my colleagues were organizing clinics Monday through Friday, 8 to 12, 8 to 2, that's where I came in and said, no, guys, we have 2-3 jobs. How is it that you're organizing Monday through Friday? I felt that this was more convenient for the professionals and providers than for the community, right? So I started organizing Friday nights, 5 to 10 p.m. Saturdays, I was out there 3 or 4 to 10 p.m. And I'm out there every weekend, organizing clinics every weekend, going close by the communities that I know that might not have access to transportation. I'm developing trust and respect. I don't know if you guys hear me all the time saying, approaching my community with the cultural relevant way. That's part of the respect, guys. And a lot of the times as professionals, we feel that, oh, great, that one thing is gonna work for all. You have many Latinos in here. You have the Central Americans, you have the immigrants like myself, you have Chicanos, you have Mexico Americans. You cannot fit all of us just because we look alike. You cannot fit all of us in one box. You must approach us in a different way. We all have the same necessities, don't get me wrong, but the approaches have to be different with each community. cultural sensitivity. That's what I've been doing. I'm approaching my community in the way that they like to be approached. I'm going to the churches, I'm going to the carnivals, and I also go to the meat markets, panaderias, and I'm also at the clubs vaccinated. The faith-based outreach, I already talked to you guys. I'm also a Vaccine Sunday ambassador for Immunize Colorado. So on every Sunday, you see me preaching, talking about the homily, combining that with public health and vaccines. And with that is language justice. My first language is Spanish. So I approach my community in their own language, right? The language that they speak. Now, that does not mean that somebody who doesn't speak their language cannot reach out to my community. That's not what I'm trying to say, but it helps to be part of the community that I'm working with.
Thank you, Julissa. Absolutely. And Julissa has, taught the rest of us the importance of just learning to say hola and just, again, speaking from the heart and being truly respectful and a servant of others. So Colorado Access unique approaches. So Julissa is going to go over a couple of case studies from her vaccine clinics, and then I will be quickly reviewing the work that we are doing with Village Exchange Center and Adelante Community Development. Julissa?
What are we doing that is different, that is very successful, right? What is it that we're doing? Well, working closely with the churches, that's one of the things that I find out that has been extremely successful, but extremely painful. You have a lot of priests who don't believe in vaccine, don't want to even think about it. And you have those that they're, yes, pro-vaccine, right? Let's do this. So I have had to deal with, the archdiocese and then dealing with priests in every church, hearing their thoughts about some of the priests think that this is a conspiracy from the government. So if their priest and their leader thinks that way, it has been challenging, for me to have a lot of success where those priests think this is a theory from the government, right? So imagine what they're telling their members of the church. But even though the churches that I have speak and we have some people that they're hesitant about vaccines, when I speak about the homily and God and vaccines, believe me, I get most people vaccinated. Like last weekend, I vaccinated 300 people. Out of those 300, 55.9% were first timers. So this is, when people talked about way back then when the vaccine started, they, oh my God, I was vaccinating thousands of people. That does not impress me. Give me your numbers now. Now, if you tell me those numbers, if you're pulling those numbers, that's what's going to impress me, because right now we're getting into what's really hard, the community that they're hesitant, they're still hesitant. So it's extremely important for all of you guys to consider, that right now it's when it's hard to have success. Before we could all be successful. I'm not impressed with none of us. What I'm impressed is the now, how many people you can get now vaccinated. So on my first Vaccine Sunday, like I said to you guys, after speaking with the church, I vaccinated 1,272 people. In any given Sunday, I'm attending 8 to 10 masses. I stay through the whole mass. I just don't come and make the announcement towards the end. I stay all day at the churches. I know the Bible by now, left and right. And not because I'm super religious, my friends, because I'm doing my job. So I'm memorizing what the priest said. And also working with schools, extremely important. I work with KIPP schools and vaccinated more than 2,000 children, right? We need to get it to the kiddos in a way also that our parents can trust us. We are leaving many communities of color behind, but we're also leaving 5 years old behind, right? So let's pay attention to that.
Thank you, Julissa. So we just got the 2-minute warning, and we've got a few slides left, so I'm going to quickly go over our other contracts. So with the Village Exchange Center, they are partnering with the Colorado Hispanic Chamber of Commerce to put on 2 medium-sized concerts, prioritizing the Latinx community, and they will be doing media. They will be partnering with clinics and providers in advance to ensure that everyone who attends the concert is vaccinated. At Adelante Community Development, they are at the Mile High Flea Market every week, every weekend, and they have a location at the flea market where they do vaccinations. And that has been a very successful partnership as well. So I'm going to just run through the next few slides. Please feel free to review them on your own time, as we don't have time right now to go over them. But they're essentially some data that 9 Health 365 collects for the Mile High Flea Market when they attend to help put shots in arms. So future opportunities and lessons learned. I'm excited to announce, if you haven't seen the job posting already, that the Community Cultural Colorado Access will be hiring 2 community cultural navigator positions, which will be on my team, and I'm really excited about this work. One will be working closely with Julissa and our Latinx community leaders to continue the valuable work that they are already doing. And the other one will be working with our Black Birthing Health Initiative. We are committed to continuing to work with other diverse communities. So we have always said, you know, Julissa is a needle in a haystack. She is an amazing community leader, and we would love to find 1 million Julissas in our regions in other diverse communities to work with. So we are continuing to reach out to community leaders and organizations to do that. And then building trust between health systems and diverse communities. We understand that we need to reintegrate or integrate folks for the first time into the healthcare system. So that they have a primary care provider who they trust, so that folks aren't running to the ER when they could be talking to a provider who speaks their language, who values them as patients. And we will be working with Julissa to do that. These are some clinics that we have identified where there is a high attribution rate of Latinx members, and they have been fully vaccinated during COVID-19. We consider these potential for partnerships with our community leaders like Julissa for future work. So I think that that's about it. And I know we're doing questions at the end. So thank you all.
Yeah, guys, don't forget to put your questions in the chat room. I love to answer questions. Thank you for allowing us to be here.
Thank you.
Thank you. Thank you for that presentation. That was so energizing. Want to introduce our third presentation today. It's Authentic Engagement to Reduce COVID-19 Vaccine Hesitancy, Safeguarding Cultural Integrity. And this is going to be presented by Lisa Lucero, Anita Rodriguez, Charlene Barrientos Ortiz, and Montelle Taméz.
Thank you. As Allison said, I'm Lisa Lucero. And we're going to go ahead and get things started by Montelle Taméz. She's going to give a little bit about an overview of the project as well as the objectives of today's talk.
Yep, happy to. Wow, so much great work happening on the ground in our community. It's awesome to hear about what everyone's doing. So one of the things that we're working on, first, I'm Montelle Taméz. I'm the Deputy Director of Community Engagement and Research at the Colorado Clinical and Translational Sciences Institute, the University of Colorado. And my colleagues here from the San Luis Valley will introduce themselves as we get going. And then my colleague also from the University, Charlene, will be advancing slides and help put these together. So Char, you can go ahead and go to the next one. So the project that we're going to be talking about today is called the Community Engagement Alliance Against COVID-19 Disparities. This is something that was funded or is funded currently through the NIH, the National Heart, Lung, and Blood Institute, and the National Minority Health Group, all under kind of that NIH umbrella. Oh, go back one. Thanks. We're one of, over 25 sites funded around the country in different states to do this work. And it was really pulled together with the express intent of reducing disparities and increasing vaccination rates, decreasing vaccine hesitancy, in communities hardest hit by the COVID-19 pandemic. So a couple of things that we wanted to cover with you today, and the things that we feel, make our project unique, at least among the other SEAL projects, is our community connector role and community data collector model that we've used in the SEAL project. We're going to go over some case studies, and Lisa and Anita are going to talk about that to kind of paint a picture of how we've done this in the San Luis Valley specifically, and to contrast how researchers' cultural perceptions and expectations often differed from the community in terms of cultural dynamics, our own processes needing to be changed and adjusted, and other aims of the project so we could fully engage community. Okay, go ahead, Sean. So a little bit more about SEAL. So the Co-SEAL project engaged urban Latinos, rural Latinos, African Americans, and Black people in urban and rural settings. In the rural setting, we focus mostly on the Somali immigrant community, and then also American Indian and Alaska Native communities. Community connectors were hired in each of those communities. Our community connectors are trusted members, trusted leaders in their communities. These are the folks who actually were project managing on the ground, and Lisa can tell you a little bit more about how that works. But we also hired community data collectors to help recruit community members for a community survey that we also did as part of this project. And we basically, our goal is to do 200 surveys from each community and to do these at 3 different time points. So it's a cohort sort of setup where we re-survey folks at 3 different intervals to see if hesitancy has been impacted and just their thinking around the vaccines and if that's been changed at all by some of the activities that are happening on the ground in community. We also conducted a process called community translation. And Lisa and Anita can also tell you more about that. But essentially, we bring community members together to develop messaging and materials that speak to their communities. So that it's not the university going in and saying, hey, we think this piece of material is going to work for you, please spread the word. It's really, the community coming together saying, this is what we want to say, this is what's important for people to know in our community. And then our community connectors and other gatekeepers really have leveraged their longstanding community relationships to engage community members rapidly and authentically in a matter of months, where it would have taken traditional researchers who aren't part of the community years to build these types of relationships, if ever. So those are just some of the basic things that we think are important. Go ahead, Char.
So as Montelle talked about, the secret to our success is investing in long-term community relationships by hiring individuals from within the community, providing education to the academic teams in regards to racism education, anti-racism education, and working within a social justice framework. That is part of why we were so successful. Go ahead and switch slides. Maintaining cultural integrity is also another part of our success. Too often we people in rural Colorado will have people come down from the big city and try to save us and do like a one-size-fits-all approach, and they won't honor our traditions or our history or even value our knowledge. But the Co-SEAL project did take all this into account when working within our community. Go ahead and switch slides, and Anita is going to talk a little bit about experience, voices, and community.
The reason we were so successful was being part to community connectors, part data collectors, part CE expert staff, and mainly it was community. Ultimately, a community without these 4 parts, we couldn't have achieved the success that we did. So yeah, it's if it wasn't for all these 4 parts, getting together, putting the different people that we needed to get involved in this, we wouldn't have been able to get the results that we did. Go ahead, Charlene.
I love being bossed around. Thank you. I'm going to take the next slide. So I'm going to talk a little bit about the social justice framework. And so folks who are in communities or in entities and in institutions and in public health. So what can we do, right? That's always the question about what can we do? So we put together quickly just a basic social justice framework. And if you include and weave these into your work and your partnerships and your relationships, this is helpful, and it is, it's not only helpful, but it's necessary. So respectfully leveraging community connections. So reminding yourself that these are folks on the ground, these are their connections. So when we use and we ask them to use their connections, we have to be respectful that we don't hurt them and we don't ask them to do things that are not okay, right? Because they go back into the community. Leveraging policy or lack of policy, or even looking at damaging policy. What does that look like? And then culturally based, talking about language, what does that look like? Their country, their county, their gender, their age, all of these, all of these factors, they matter. It is not just about race and ethnicity, but what does that look like? And it is culturally based. And then addressing and acting upon inequities with testing and education and vaccines. This really, COVID really highlighted all of the racist and systemic racism pieces that were there for us. And so when we wanted to go and partner, we had to first internally talk about some of these topics before we even went into community, and we had to be transparent about what we could not do. Lisa?
The community connector was a big part of our success too. And I never thought of myself as a community connector until I was given this position with COSIL. But when they were looking for community connectors throughout Colorado, they were looking for a trusted person that was, preferably a native to the area they were working at. Bilingual was good because of the different populations we were working with, whether it's Somali or monolingual Spanish speakers. It was important that not only did they know the culture, but they knew the language. And somebody with proven leadership. As a community connector, I was charged with finding a group of data collectors, as well as participants of the boot camp translation process, which I'll talk a little bit more about a little bit later. But when looking for data collectors, I really thought about how to obtain the best data we could possibly obtain in the San Luis Valley. So data collectors came from, they're all from the Latinx community, but very different backgrounds. Sometimes they just kind of group all Latinos together, but we're so different. So some had an MBA, some had BAs, some had high school, education, some were bilinguals, some had children, some didn't have children, but really want to work their sphere of influence to get the best data available. So Anita was one of our data collectors, and she's going to talk a little bit about her experience.
When Lisa contacted me to be a data collector, it basically needs to be somebody that knows the community. Also, like she said, be bilingual, because in the community that I had that they entrusted me with, it's all bilingual pretty much, knowing that the people that we had to engage in for these surveys, they had to be somebody, they had to choose somebody that was trusted, somebody that they're going to trust in the community. So I didn't really consider myself, as like Lisa said, to be a leader in the community, but I guess I am, because I do help out in a lot of different organizations. So yes, I do consider myself now as a leader in the community. And sorry about that. And we have to know our people. We have to know our people, and to be able to get the people that we chose for these surveys, you just need to know. You need to know who and they need to know that they can trust you. So, we recruited people for this that we obviously we know, and also, we have to uphold our cultural integrity. So go ahead.
So another thing in regards to data collection, I'm getting feedback. Is everybody getting feedback? Okay. In regards to data collectors, is I want to build capacity within my community. So I wanted to find leaders like Anita who didn't know how amazing they were, and that they were leaders, and grow their capacity to do even bigger things for our community later. The whole process was inclusive of all and flexible at all stages of the project. I mean, initially in regards to data collection, we were told to preferably do it in an online format, but that doesn't work in this San Luis Valley. Not everybody has a Wi-Fi or even a Wi-Fi signal in some of remote areas. So we switched it up, and we did paper copies predominantly. So things of that nature. We were always.
Yeah, it's like Lisa said, we had to do paper copy because a lot of the people don't have the Wi-Fi. So I would have people come to my home, and because of the COVID, and everything, I would always make sure that they had a mask, and I was always, also with my mask on. So to protect, not only myself, but protect themselves. So whenever the case was that they had to come to my house, my home, we were always respectful, but we did have that where we had to go to their house. So that's what the paper copy came in, where, we could go back and put the information in that we did need to put in for this surveys.
Go ahead and switch slides, Charlene. So one thing that did come out of this is Anita's the local expert on COVID in the center area. So do you want to talk about how our Plática came about? Because people knew you did work around COVID.
Okay, well,
vaccine hesitant.
Yeah, not only am I part of this team, but like I said earlier, I am a part of different groups. One which is called PICS. It stands for Parents Involved in Center Students. So we every 2 weeks we have a meeting with our parents from the school, and we decided that we needed to talk about COVID. So they asked me, okay, who do you know that would be able to do something like this? So I contacted Lisa. Lisa, can you get a hold of some doctors for us? Some professionals that would be able to answer some questions on whatever our parents would need. So then Lisa was able to contact some professionals. Go ahead, Lisa.
So at our first meeting, it was in January, we actually had 117 people attend, which was almost unheard of on a Thursday night at 6. And the people that attended were, the PICS group that Anita was a part of, directors of social services, directors of public health, people from Alamosa, from the various counties in the area. And then there was some method to our madness with the format of that particular programming. The first part was delivered in English with Spanish translation. And then the talk with the doc was delivered in Spanish with English translation. And the method to our madness is we wanted English speakers to learn something about how things get lost in translation, and how we have a ton of monolingual Spanish speakers who are making choices about their health with half of the information. And it was eye-opening for a lot of people. So, hopefully something good came out of COVID. You can go and switch slides.
Oh, wait, hold on. And with this, with our first meeting that Lisa was saying, our parents didn't have enough, they wanted more. They wanted more information. So then again, we contacted Lisa and we said, okay, Lisa, we need to get a hold of the same people that were on our first meeting. And so that we could, our parents want more information. They wanted that one-on-one more with the doctor, so that they could ask different questions that weren't able to address. And this time they had, time to prepare their questions and stuff like that. So yes, the second one, it wasn't as big as a big one, the first one with 114 people, but we did get a good number. I think we got like 40 something people on our next, but this was just now our parents group. Besides the parents the people that did come in from the Department of, I forget what it's called, Lisa, the doctors and stuff like that. But yes, then they were able to ask more questions. And then it was already questions on the Omicron, so it was already different. It was already different as opposed to when it started. So yes, now we got more information and we got a lot more people interested in getting the vaccine for the little ones. So hopefully we'll be able to get vaccinated for the little kids, from, I don't know, the age group that they're wanting to do now. Hopefully we'll be able to start that here. Go ahead, Charlene.
So one of my favorite portions of the project is it's called Boot Camp Translation, and it leverages the expertise of community members to translate scientific evidence and guidelines to locally relevant stuff, whether it be messages, campaigns, materials. Typically, a boot camp translation will take 9 months. This one took 8 weeks. We, as a result of that, community members from all around the Valley got together to address vaccine hesitancy. They believe the best way to do that was through storytelling, because that's how we get a lot of our information across. What resulted from that is a website called Our Stories SLV COVID. So if you get a chance to check it out. We also had some rat cards with information about COVID numbers and Latinos, and then personal stories of community members that may have lost a loved one or who has experienced COVID. We had banners, and the way we disseminated the information, go ahead, switch, Charlene, is through trusted messengers. We partner with a couple of local churches for Dia de los Muertos celebration that included a COVID-19 vaccine bus.
I'm sorry, the slides are not advancing because they're frozen. I apologize.
And next steps, Charlene, do you want to talk a little bit about next steps?
I think I can.
Yeah, go ahead, Montelle, if you
Okay.
don't mind.
Yeah. So, and I also see that we have the 2 minutes. So thank you, Anita, Lisa, Char. This has been so far a difficult process, but a very rewarding process. I think the takeaways are, coming from an academic sort of research environment, being, really committed to working with the community and taking direction from the community in this work is super, super important. We've received a second year of funding for the Co-Steal project from NIH, and we will be continuing our surveying of the community. So Anita has been very helpful in helping us to put training together as we bring on new data collectors. Really, the community, our community folks are really helping to drive this process so that we're trying to ensure that it's relevant and meaningful and accessible for folks. We'll be doing another round of the community or bootcamp translations, developing more materials and more messaging for folks. We're working right now on doing this to focus on pediatric vaccines. So instead of adult vaccines, like our first part of the project did. So right now we're working with parents and children and trying to increase vaccination rates and decrease hesitancy. So I put the website that Lisa referenced in the chat if anybody is interested in clicking on that and taking a look. Also, all of our other communities are available on the Co-Steal website as well. So thank you.
Thank you. Again, it was so great to hear all the different perspectives from all the people on your team. So thanks for kind of doing that big group presentation for us all. And now I wanted to allow our audience to ask some questions and see if you wanted to kind of talk about some of the themes you noticed kind of throughout the whole presentations, just about different vaccine strategies, or just wanted more information about any of their different approaches. As people can start thinking about questions, I had one that I wanted to ask, just because we're kind of getting into a new stage of the pandemic where we're shifting from the emergency response to the endemic response. And I was just wondering if some of the presenters could weigh in on how this is impacting your funding or any of your outreach strategies more broadly, and if we need, and if we as participants need to be advocating for more resources for you all, if that's the case.
Let me start. This is Julissa Soto. Yes, we need all of you guys to advocate for more funding, because the fight against COVID, it doesn't end here. Yes, the Anglo community might be talking about an endemic, but we're still playing catching up. I'm still on first and second vaccines. For me, COVID is not over. For my community, it's not over. So we must advocate and see for more resources. Our community is freaking out right now. And I'm freaking out too, because, you know, I'm representing Colorado Access, and with Colorado Access, they're doing their best that they can for their rate, which is 3 and 5. But what about all the other rates? What about the rural communities? What about San Luis Valley? What about, you know, Delta, Montrose? So I know that we're all stressing out this week, especially with the closures of many of the testing sites and clinics this week. And without even further notice, they just closed the state, right? So yes, we need all of us advocating. We need to show up and say, no, you can't continue mistreating people of color. I thank God for COVID and not, right? Because a lot of people died during the COVID pandemic, right? But it illustrated all the inequalities in the way that we've been treating for many, many years. But it happened to be that a lot of people just noticed these past 2 years. But we've been treated like this. We have been dealing with COVID all of our lives. No access to care, dying. We have had COVID all of our lives. It's just that now it illustrated, you know, with a pandemic. And here we are talking about endemic. It's no endemic. We're trying to catch up. What about my other colleagues, Montelle, Anita? What do you guys have to say about this?
I agree. We are still playing catch up. I think, you know, the decision to sort of close down the buses and making things less available probably was the way to go for our communities. Again, you're right, Julissa, we're still playing catch up. I do think, to the extent possible, continuing to fund, you know, this work is very important. Making sure that communities have access to funds, that they have the ability and the flexibility in using those funds in the way that they feel best serves their community and the populations that they're trying to reach is absolutely imperative. And I think also one of the things I've noticed, at least attached to federal funding, I'm not so sure about state funding, but decreasing the administrative barriers to accessing those funds and to utilizing those funds, hugely important. This is a huge time commitment. It takes a lot of folks to administer these types of programs. So from my perspective at the university level, that's what I see. I'd love to hear from Lisa and Anita.
I also agree with you, Lisa. Also, yes, we are playing catch up, and we still have people that are not convinced on getting this vaccine. You know, so we still have to go out and, you know, try to talk to them however we can so that we could get all our community, you know, everyone in our community vaccinated. So yes, definitely have to find a way to keep this going, because yes, we still need to catch up, and we can't just end it there.
So this is Charlene, and I'll address the question about how did you identify local individuals to assist in these efforts. So, you know, one of the things is that I'm the community engagement person on the grant, but I'm native to Denver and native to Colorado and have family and connections all through the state. And so leveraging those relationships and reminding my team and even the community what that looks like. And so I'm able to bring people to the table. And I want to share this and share this with folks on the call. So there are usual suspects and there are unusual suspects. The usual suspects are the folks that everybody always calls on when there's a public health group or your coalition. They're the same folks. A different way to look at this is looking at what I call the unusual suspects. These are gatekeepers that which are quote unquote hard to reach. but they're willing to do the work on behalf of their community, for their community, and with passion. What I would say is that looking at those connections, working with folks like Lisa, honoring and respecting the communication and the connections that Lisa has. So Lisa's on the call, and so we really looked and for her direction and who that looked like. Our program and our grant decided to do that intentionally and authentically. So Lisa was able to hire who she needed and who she wanted. It worked. She knows her community. So that's how we were able to identify. We went into communities, but I'm also not foreign to the San Luis community. I mean, I'm connected there as well. But knowing that I don't live there, I had to then take that layer off. And again, it goes back to that social justice model and honoring and respecting what's already there. Lisa, what do you have to say about that?
I think that's so important, and that's why it was so successful, because I did have the ability to hire who I thought would be best for the position to reach the people that we needed to reach. So I was thankful to have that opportunity.
So I will answer the question for Julissa. Were your clinics at the churches you spoke at, or do you promote the vaccines and have them scheduled come to a separate clinic? No, mija, or mijo, or whatever, right? I just call people mija and mijo. I'm sorry, it's just a term of loving, you know, I'm not offending anyone. So basically, you're already at the church. You already have a captive audience. Why going to promote somewhere else? Organize the clinic itself there, have the clinic there, and speak during all the masses, English or Spanish, but don't go nowhere else. If you're already at the church, my other clinics that I have at La Plaza Colorado, for example, or at the clubs and everything else, I promote them anywhere else. I go to the businesses around the area that I'm gonna be, but not at church. At church, I promote only the church clinics. I have other strategies when I conduct health clinics and other places, which is the club, the meat market. I go to the trailer parks, and when I organize in apartment buildings, vaccine clinics, I do my outreach a little bit different.
Thank you all so much. Yeah, it's disappointing we don't have more time to go into the Q&A because we had such great presentations today. But I just wanted to give some wrap-up announcements. Thank you all for attending the session today. The slides and any additional handouts are available on the conference platform Schedule, and you'll receive a conference evaluation form via email after the conference is over. We are encouraging you to fill that out just to give us some more feedback, so when we're planning next year's conference. And we also have the opportunity to enter into the raffle to win one of two $50 gift cards. And now we are going to have a 30-minute break, during which we encourage you to listen to the recorded walk and talk session, which will allow you to step away from your screen. And the presentation is the impact of data collection on access to healthcare resources among Native American communities. And if you want to log back into the next live session, that will begin at 2:45, and that will be another concurrent breakout session. You can see the full schedule on the Schedule conference website to determine which one you would like to attend. So I just wanted to give our speakers a big thank you again, and thank all the attendees for being here and having such a rich discussion today. And we'll see you back.
Yay! Adios.
Bye. Thank you all.
Bye.